Hotbed Talk.
This piece is part 1 of 2. It's a short presentation by the host of the session, Sol Aronson, tenured professor, Duke University. Have a listen.
This next session entitled Models of Perioperative Care, Gaps in Opportunity. What we are all very familiar with in the U.S. is that our healthcare system is really founded on I would call an unstable foundation. It's a health system that is predicated on an employer-based delivery of healthcare, something that made sense after our troops came home following World War II as an enticement to get employment, as we had salary caps back in those days, 70-some years ago. But over the years, what we've seen is that there's just been this disproportionate rise in the cost of healthcare that has significantly outpaced the cost of inflation, so that we're now confronted with escalating costs, and yet we still have this tethering of our healthcare provision to employment. That means that there are many people who are outside of the employment healthcare domain, and we've seen in this last year, because of the pandemic, is that has just been stressed even beyond what we had already noted as a chronic, if you will, continuation of an unstable healthcare system. It's estimated now that there's probably between 10, some have even estimated up to 20 million people who have been added to the unemployment rank, which means added to the uninsured rank, which is another significant stressor, external stressor on our healthcare system. So we are really having to have a unified national strategy, whatever ideology you come from or bringing to the discussion. I think there's a unanimity of opinion that we need to bend that cost curve. In lieu of that, the conversation is really focused on value, and we all have a sense of value being a component of quality and cost. But what we often do in that conversation is misrepresent value, and we don't fully appreciate that the cost of care for the entire episode is something that we need to think about. And as a consequence of that, what we have tended to do is cost shift as a short-term, what I would even consider a myopic, if you will, approach to dealing with value proposition. I think what we're seeing now, because of the intensity of stressors and policy that is intersected with our realities of just affordability, is that we are in the process of re-engineering our healthcare system. And I think that's going to be more likely the primary input rather than a question of access. It's now a question of how do we re-engineer. And I think what we'll soon understand is that a best approach to a truly re-engineering a healthcare system is for us to accept the fact that we're going to need to spend some money in order to save the totality of cost of care. The intended and unintended consequences of perioperative care, as it pertains to the space that we're most comfortable to discuss, is, I think, a story that began many, many decades ago. As early as the 1950s, there was a report in the St. George's Hospital of London that really spoke first, as I can tell, about outpatient anesthesia. And I think there's a really prophetic quote that was raised in that article. It reads, "I think that an anesthetist outpatient department could contribute considerably to preventative medicine. The anesthetist is frequently confronted with a patient who is not in the best possible state for operation. He or she has been made as safe for surgery as possible. For the anesthetist to see the patient the evening before operation, or even 2 to 3 days before operation, is not enough." As early as the 70s, a group of surgeons in Phoenix were the first to really introduce the concept of an ambulatory surgery center. I think it's interesting that came forward because there was a need for OR slots. They were upset that they couldn't get their block times, and they came up with the concept of an ambulatory surgery center. I think since then it's been really a pervasive phenomena that we've seen has just escalated significantly in growth over the last few decades. As the continuum continues in perioperative medicine, we see and have seen in the 80s that preoperative assessment the night before surgery was routine. That's when I grew up. That's when I was doing my training. And it was very commonplace for those younger people listening, for those of us who were in anesthesia to routinely make rounds after our day's cases to see our patients for the next day who were admitted into the hospital the night before surgery. And we would see them and do a cursory review of their history and physical exam and do whatever laboratory testing we thought reasonable, literally the night before surgery. In the 90s, same-day surgery began to grow and was more and more commonplace. I think we began to appreciate the need for bed utilization and the silliness, if you will, of bringing people in the night before when there was no other good reason. And as a consequence of that same-day admission growth behavior, the pre-anesthesia testing clinic emerged, and that became an independent, standalone entity. And we even today use as our oftentimes routine way of assessing patients before surgery. Of course, in the latter part of the 90s, enhanced recovery became more and more pervasive. Dr. Cullett's remarks, I think, were again prophetic way before his time. He wrote, preoperative evaluation and care are essential for optimal surgical outcomes and provide health benefits long after surgical intervention. The 2000s demonstrated a whole lot of external inputs from value and tension of the external markets. And so we began to see really disruptive forces permeate throughout surgical care, as well as innovative techniques. Non-invasive surgery became more and more commonplace. Our outcomes improved as a consequence of that. And our lengths of stays, I also believe, reduced significantly as a contribution of those innovative surgical approaches. But there was also, in addition, a greater forces, external forces from the marketplace, so we became more in tune to episodic care, functional recovery. Certainly enhanced recovery became commonplace, if not routine. And throughout all of this, ambulatory surgery centers began to continue to proliferate and now today represent greater than 50% of all surgeries conducted in the U.S. In the last decade, I think what we've seen and are continuing to see is an evolution of preoperative optimization programs becoming more and more introduced into our vernacular. With that said, I think there are really 5 added and tiered, if you will, elements to the economic evolution of pre-anesthesia testing. I think we're all familiar with the benefit that we have seen from pre-anesthesia evaluations, reducing surgical delays and same-day cancellations. And we've also begun to appreciate that when there's true care coordination, waste reduction in the form of less tests ordered, unnecessary tests or redundant tests or diagnostics have certainly contributed to the value proposition. We've also seen that there's a growth in the component with a fee-for-service market that we still principally practice in, that there is contribution margin when we appropriately conduct our indicated medical behaviors according to necessity and define them outside that which is incident to the delivery of surgical care. I think the real benefit to pre-operative rehabilitation or pre-anesthesia optimization programs is going to be seen in the area of cost avoidance. As we become more and more closer to value proposition and value-based care, I think it's the risk mitigation and the cost management consequences of what we do preoperatively to prepare our patients to make them ready for surgery that will be seen as a cost avoidance and be interpreted as a value add downstream. And eventually, and I think it is a goal for all of us in perioperative medicine to really think about how we can more fully integrate what we do in the broader context of population health. Population health is a big nut to crack. It really represents 80% of the true cost of care when we look at healthcare in a policy sense. And I think what we do with respect to managing the realities of nutrition and education and work and just the neighborhoods that we, show ourselves to be available to is going to have the greatest impact. Couple statistics that I think are phenomenal, and I'm going to just share them with this group. If you are born and are raised in the Midtown Manhattan compared to the South Bronx of New York, your life expectancy has a 10-year differential. And similarly, if you were to be raised in the downtown Chicagoland area versus the west side of Chicago, you would have a 16-year diminution of your life expectancy. So population health as it pertains to where you're born, how well you grow and where you grow up in the neighborhood, how you live, work, and your age is significantly important. A couple facts and gaps about healthcare in the U.S. If we do 320 million cases a year worldwide, it's probably true that 50 million of those procedures are conducted in the U.S. alone. The average person in the U.S. will undergo about 9.2 procedures in their lifetime. That's a phenomenal statistic to think about it, and one that I just simply had to read more than once to believe. Um, Surgery nevertheless accounts for a disproportionately expensive cost of care. If you look at all the things that we do in our lifetime that are related to healthcare expenditure, it's really important to understand that although surgery represents a small sliver of that continuum of our life cycle, it is a disproportionately expensive component of time care sense. And so things like 30% of hospital admissions account for more than 50% of the true cost. And so what that means is there are opportunities in perioperative medicine to really bend the value proposition curve are disproportionately great. And I think we should really appreciate that, because the costs, the complications, when they are attributable to surgery and related, are very, very expensive, and they range from $10,000 to $50,000, and not the least of which is the length of stay of a hospital stay itself. All that said, what we found and others have repeated is today it's true that nearly 20% of people who undergo elective surgery are not optimally ready for surgery, that there are many chronic comorbid medical conditions that can be modified to make that patient more fit, if you will, for surgery. So while we try to figure out how we can bend the curve from a healthcare perspective, I think it's important to know that the payers are not waiting for the providers to figure this out, that we've already shifted our risk profile from that fee-for-service to a, if you will, global or capitated system well beyond a shared savings. We're certainly, depending on what region of the country we come from, well within that two-sided risk, shared risk and shared savings, total cost of care environment. And I think we're moving continuously down that continuum toward true value-based care. What the payers have done over the years while we've been figuring out what to do on the provider side is that they've steered us to, as best they can, good behavior. Some could argue policed us. We certainly are familiar with the provider networks and co-pay steerage, pre-certification and high deductible plans. But lately, what we're seeing is that there are now some very proactive programs that are forcing providers to take significant penalties if they don't steer their patients to low-cost providers or low-cost environments. And in some cases, providers are now refusing to even pay for services unless there's a prescriptive, if you will, intent to do a procedure in a low-cost site of service program. So the payers are not waiting on this. In perioperative medicine, there are a few things that I think we can do, and I hope to trigger the discussion in the panel. I think there's great discussion, lots of important discussion on staffing our services to top of license, and we can speak a bit about care team models and best practices. Certainly, coordination of care is a buzzword that has great meaning, and how we design our care delivery models to improve value. Reducing waste and misuse of services is always important, continues to be. And reducing variation. I think one of the most important things about the ERAS programs is that it has really forced us to protocolize the way we provide services, and in a consequence, reduce that standard deviation and the waste that goes with variation. I think we're going to see more and more steerage toward site of service where the procedures that can be done at the lowest cost environments will be done there because of incentives. And I think it opens up a whole area for what I'll call the science of value. I think what is nascent in our biology and physiology practices is to really understand how to apply innovative technologies and to study, if you will, the biology of safe practice and what constitutes tolerance. So I'll conclude by just saying that we've published this cartoon in an article a few months ago that really, I think, nicely outlines all of the variables that we can begin to focus on to think about bending that curve. And as we go further down that road and really develop the science of value, I think the costs will follow the outcomes that we are now going to be able to create. And with that, I'm going to end and open it up back to you, Desiree, to have the panel discuss this. Thanks so much.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.